Hello and welcome to a pathology discussion of CBT. So all of the following, let's begin. The first question, all of the following are features of hemolytic anemia except. So all of the following except, so they're asking which is not a feature of hemolytic anemia. Hemoglobinuria, jaundice and hemosideruria, these are pretty much direct question where it's asking you what changes will you see in blood, in the peripheral blood and in the serum. So hemoglobinuria, jaundice, hemosideruria in very severe hemolysis. In very severe hemolysis this can be seen. And as I'm sure you all have marked correctly, increased haptoglobulin levels is the answer here. In fact, in hemolytic anemia, there is decreased haptoglobulin levels because this is a protein that binds to hemoglobin. And if there is a lot of hemoglobin, you try to catch hold of it, you'll not be able to measure it. The hemoglobin levels are more, so haptoglobulin levels are less because the amount of haptoglobulin value measure, you're not going to get the same amount that was there before the hemolysis started. Now, characteristically, we see it in intravascular hemolysis, but of course, we can also see it in extravascular. You have to pick one answer. The option is intravascular hemolysis. I hope the rest of it is clear. The jaundice is going to be unconjugated. The jaundice is going to be unconjugated, and hemoglobinemia plus hemoglobinuria can be seen. What is the most important point under hemolytic anemia? Please remember there will be reticulocytosis. There will be reticulocytosis, extremely important point. Next, Philadelphia chromosome seen in chronic myeloid leukemia produces a protein called. So first of all, let's clarify some basics. What is Philadelphia chromosome? Philadelphia chromosome is chromosome 22. Philadelphia chromosome is chromosome 22 after translocation 922 has occurred. On this chromosome, there is fusion of BCR and ABL1. BCR ABL fusion में ABL sequence remains the same sequence, whereas BCR can vary. And depending on combinations of these two, you get different kinds of products. So if it is an exon called major BCR, the protein that you get weighs 210 kilodalton, which we call P210. If it is minor BCR, it is a protein which is 190 kilodalton and we call it 190. Major BCR is seen in chronic myeloid leukemia. Minor BCR is seen in acute lymphoblastic leukemia. In CML, it is good prognosis because it responds to treatment. In fact, you require this for diagnosis. Whereas in ALL, when this is present, it is bad prognosis because it does not respond that well. It does, but it doesn't have that same kind of good response. At the same time, ALL, which has this kind of translocation, can show aberrant myeloid expression as well. This is just an extra point I wanted to throw in there. It can also show aberrant myeloid expression when this kind of translocation is present. So remember major BCR, which is denoted as capital M BCR. It is denoted as capital M BCR, and this is denoted as small m BCR. So now when you look at the question, I hope it makes sense. Philadelphia chromosome seen in chronic myeloid leukemia makes a protein called P210. P190 is seen in ALL, and P230 is actually micro BCR, which makes a 230 kilodalton ka protein, and this has a very varied expression, so you need not know about it. Next is a 62-year-old woman presented with headache, chest pain, weak pulses in the upper limb. So what is she? She's a 62-year-old woman, headache, head symptoms, chest symptoms, and weak pulses in the lower limb. So something vascular is possibly going on. Aortic arch is the site of biopsy, and it shows granulomatous inflammation with fragmentation of internal elastic lamina and a narrowed lumen. So what's your diagnosis? So till now, with this information, you should be clear that it's aortic arch, so it is a large vessel and it is granulomatous inflammation, so we are looking at some kind of vasculitis. So what we are looking at is a large vessel vasculitis, and we know that large vessel vasculitis usually presents with granulomatous inflammation. And as I always say, once you come till here, you just have to look at the age of the patient. If it is more than 50 years, it is going to be giant cell arteritis. If it is less than 50 years, it is going to be Takayasu arteritis. This is a very crude way of approaching this question, but it will get you the answer. So in this patient, I have put this specifically because we know that for giant cell arteritis, the most common artery involved is temporal artery, and in Takayasu we know that it is subclavian. The aortic arch and the branches are more common. But here this patient is 62 years old, and here aorta is involved. So the age is more important. More than 50 years, I'm going to call it giant cell arteritis, and since it's aorta, it is going to be giant cell aortitis. I hope this distinction is clear. This was asked in PGI as well once. Polyarteritis nodosa is a medium vessel vasculitis. So is Kawasaki. Both of them are necrotizing. Arteritis. Fibrinoid necrosis is the kind of necrosis you see here. What is a necrosis? Fibrinoid necrosis is the kind of necrosis that you see. And what are the two important points about their distribution that you should remember? PAN के बारे में what are the points you should remember? First is that it spares bronchial arteries. It spares bronchial arteries. I'm sorry, it spares pulmonary circulation, and in that it spares pulmonary arteries. Bronchial arteries may be involved. I'm sorry, because our Robbins has not been very clear about this. So it spares pulmonary circulation, but it may involve bronchial arteries. And what is the other thing? Renal involvement is quite common. It has patchy involvement. And all stages of activity can be seen at the same time. So you can get a very acute presentation and a very late chronic presentation as well. Kawasaki, as we know, classically involves coronary arteries in children. So that's about this question. I also brought a photo for you to see if you can just appreciate. We know that the layers of the vessel are your single layer of endothelium, tunica intima, and then you have the muscular layer, which is tunica media, and then you have your adventitia or externa layer, that is tunica externa. Now here is the lumen. So if you look at this photograph in the center here, this is the lumen, because I can see all the RBCs, and I hope you can appreciate how this is the muscle. So if this is the lumen and this is the muscle, this entire area has to be the intima. And this is a very important finding of this kind of vasculitis, that you get intimal hyperplasia. Same thing here. This is the lumen and this is the muscle layer, and in between the stain is von Giesen stain. This is the von Giesen stain, which is used for elastin, and here between these two intima and media we have a layer called internal elastic lamina, and between media and externa we have external elastic lamina. So I use this stain, which is a silver stain, to visualize elastin, and I hope you can appreciate how there is this kind of weird stuff going on here, which you can appreciate the waviness of the internal elastic lamina. And right here it is disrupted. So this is disruption or fragmentation of internal elastic lamina, which is a very important finding of this kind of vasculitis. And you may not be able to appreciate it, but trust me if you will. There are some giant cells here which are a little indicative of your granulomatous inflammation. So when you put all three together, intimal hyperplasia, disruption of IEL or fragmentation of internal elastic lamina, and granulomatous inflammation, your diagnosis is large vessel vasculitis. Then depending on the age and the site, you will decide what kind of entity it is. The Minimum length of biopsy required is 1 centimeter, whereas ideal length for biopsy is around 3 to 5 centimeters. Biopsy is the diagnostic technique. You cannot diagnose it without a biopsy. So see, appreciate the role of the pathologist. Okay, next, McCallum plaques are seen in. So first of all, what are McCallum plaques? McCallum plaques are subendocardial lesions. These are subendocardial lesions, plaques, which are seen in rheumatic heart disease due to regurgitant jets which make plaques, and they are seen in the left atrium. Usually on the posterior wall, to be even more specific, on the posterior wall. So I brought a photo just so if we can see, you can remember it. I always find it's easier to correlate. So if you can appreciate in the center here, you can see a plaque-like area. This is a McCallum plaque. This is a left atrium that has been opened very nicely. You can see the ventricles thick, and this is your valvular apparatus. If you notice closely, there is some kind of thickening here, which are probably the vegetations. And this is a little dilated left atrium in my opinion, and when you open it, you can see this kind of plaque. So I hope it's a direct question. I hope it's clear. Now, loss of which of the following protein is implicated in aiding of the metastasis of tumor cells? Please remember the key word here is loss of which protein. So we know that integrin is a part of extracellular matrix, and it helps in cell 2 ECM adhesion. It helps in cell 2 ECM, extracellular matrix adhesions. These two here help in dissolving or breaking down your matrix. They help in breaking down the matrix in order to infiltrate and aid invasion. And here is a very important protein, that is cadherins. We have two kinds of cadherins, E-cadherin and N-cadherin. E-cadherin is the one we have to remember. E-cadherin is coded by a gene called CDH1. This is important in contact inhibition, and CDH1 gene is implicated in diffuse gastric cancer, and in lobular breast carcinoma, as well. So when CDH1 is gone, E-cadherin is gone, and E-cadherin is a component of desmosomes, and this is important in order for the cells to lose their adhesion to each other and then move on and cause metastasis. Hence, if I ask you, which is that one protein which is jiska loss is implicated, the answer is E-cadherin. Now here I brought a little photograph for you to see from Robbins only, just to understand how metastasis is occurring. So the first and the most important step is there has to be loosening of the intercellular junctions. Do you see these hair-like processes here? All of them are the desmosomes which are containing cadherins, and you can see collagen and laminin. They're all attaching the cell to the basement membrane. Basement membrane has type 4 collagen and laminin. It also has fibronectin, which is usually important in making the scaffolding of the extracellular matrix. The next step which is important is degradation of ECM, degradation of the extracellular matrix, and this is where your 3 MMPs, your type 4 collagenase, your cathepsin and plasminogen activator, all of these come into play. They break down the matrix. And finally, there is migration and invasion. The cell becomes this epithelial cell. This epithelial cell will now take on mesenchymal characteristics in order to get into the stroma. So this is very nicely called epithelial mesenchymal transition, EMT. And once it reaches its new home, it undergoes something called MET, which is mesenchymal epithelial transition, and all these changes that occurred are going to occur again in reverse in order for the mesenchymal cell to become epithelial and then form a new nest of tumor. So I hope this is clear. Cathepsin, plasminogen activator is another question that they've asked. Next is ductal carcinoma in situ. So in situ is the keyword here. DCIS can be differentiated from IDC, by all of the following except. So basically what this question is asking you is which of these four conditions or which of these four histological features are not going to help you to differentiate between the two. So let's look at each option. Nuclear pleomorphism is present in both. Nuclear pleomorphism is present in both. Basement membrane invasion is present only in IDC. That's how I know it is not in situ anymore. Loss of myoepithelial cells, again seen in, I'm sorry I shouldn't write present, seen in IDC. That means no myoepithelial cells in IDC. Central areas of necrosis are more seen in DCIS, and here when we see it centrally we call it comedonecrosis. It is also seen in IDC, but the comedonecrosis is a very characteristic pattern. It's seen in high grade DCIS. So as you can see, the first feature, that is nuclear pleomorphism, is not going to give you any information whether it is, if you just look at those cells, you cannot tell whether it is DCIS or IDC, just the cells. We're talking about cellular morphology here. I hope that is clear. We're talking at the cellular level. Of course, once I establish that basement membrane is gone, it becomes IDC. Now here just another point you can remember is that IDC-NOS is the most common histological subtype. This is the most common histological subtype. Please remember, histological subtype is the keyword here. Okay, next question. All of the following points are true about Lynch syndrome except. So first of all, what is Lynch syndrome? Lynch syndrome is named after this Wharton-Lynch syndrome. And this is another name for your HNPCC, hereditary non-polyposis coli cancer, which is also a hereditary condition in which colorectal cancer arises. In fact, this is responsible for around 3 to 5% of colorectal cancers. This is the most common familial condition leading to colorectal cancer. Familial syndrome, cancer syndrome leading to colorectal cancer. Now the features of this are very interesting. First of all, it is seen in younger patients. It is seen more in women. It is seen mostly on the right side. In fact, the classical description that CAP gives is, the College of American Pathologists, they say that proximal to the splenic flexure. Proximal to the splenic flexure is the most common site. And intratumoral lymphocytes are very common. Intratumoral lymphocytes are very common. In fact, when we see these, we start suspecting that maybe there is some kind of syndromic involvement. And the histology is usually mucinous or signet ring cell. Signet ring cell. And these tumors are basically MSI-H, which are high microsatellite instability, which is a DNA repair issue. MSH2, MLH1 are the genes involved. So when you look at this options, look at the options, left colon is involved more. Is that true? Is the left colon involved more or the right colon involved more? The right colon is involved more, right? So this is the answer. Endometrial cancer is the most common extracolonic tumor involved. Yes, this is very true. Endometrial carcinoma type 1, which occurs with hyperplasia and unopposed estrogen exposure, is the kind of cancer that you see. Intratumoral lymphocytes are more, yes, and they are seen in younger age group. In fact, I think around 35-40 years is the mean onset. So next, which of the following is the most reliable feature of malignancy in a paraganglioma? Please make note that whether they ask paraganglioma or pheochromocytoma, it is one and the same thing. Pheochromocytoma is adrenal, paraganglioma is extraadrenal. Now I know some of you have had doubts here, so what I've done is I have opened Robbins here to show you the actual lines so that you don't have to doubt me. See, I'm coming with support. So there is no histological feature that reliably predicts clinical behavior. In fact, therefore, the definitive diagnosis of malignancy is based exclusively on the presence of metastasis. Why is that? because even capsular and vascular invasions may be encountered in benign lesions, and tumors with benign lesions may metastasize, whereas bizarrely pleomorphic tumors may remain confined to the adrenal. Presence of giant cells, mitotic figures are also often seen in benign pheochromocytomas, and cellular monotony is paradoxically associated with an aggressive behavior. So as you can see, there is literally nothing that we can look at histology and comment on what kind of will this tumor metastasize. So the moment it metastasizes, you know that it is malignant. And what are the common sites? Regional lymph nodes, as well as liver, lung and bone. So I hope this rests the case once and for all that the most reliable feature of malignancy has to be presence of metastasis, whether it's paraganglioma or pheochromocytoma. It sounds weird, I know, because vascular invasion sounds like it should be malignant, but the answer is presence of metastasis. One of my favorite questions. Which of the following is not true regarding genetics of thyroid tumors? So let's look at each option. Driver mutations in KRAS are seen in follicular. So before I go here, how about we draw a diagram just to remember the genetics. This is my cell membrane. Say this is a receptor called RET receptor, which is a growth factor receptor. This is a growth factor receptor. Okay. Downstream from this, you have a signal transduction protein called KRAS. And then further downstream, you have another signal transduction protein called BRAF, and say another protein called PI3K. Then they have their own further signal transductions, and finally the signal for growth reaches the nucleus, where you have a transcription factor named PAX8. This is a transcription factor. So these are the most commonly involved genes in thyroid carcinomas. So let's look at each one. RET proto-oncogene or RET growth factor receptor has two kind of manifestations. If it undergoes a mutation, please remember M for mutation, M for medullary carcinoma. Okay. Whereas if it undergoes translocation, it is seen in papillary carcinoma. So I hope these two terms are clear. Mutation is going to be a change in the sequence of DNA, whereas translocation is not a change in the sequence, it is a change in the location. So the problem is because of the neighbor, not so much because of what has gone wrong with the gene as such. So if I ask you where is translocation of RET or rearrangement, that's another term we can use, rearrangement of this RET gene, that is also the same thing as translocation. So RET rearrangements are seen in papillary, whereas RET mutations are seen in medullary. KRAS is seen in papillary carcinoma, follicular carcinoma. KRAS is follicular carcinoma. BRAF, if you recall from Bachpan, where you've read these conditions, so BRAF is also papillary carcinoma. In fact, these are the most common mutations in papillary carcinoma. PI3K को one factor inhibits it. The name of that factor is P10. P10 is a tumor suppressor gene, everything else is a proto-oncogene. And both of these mutations are seen in follicular carcinoma and anaplastic carcinoma. In your Robbins, there is another really nice table given for this, and I'll just show it to you to make you see if you can remember it well. So let's look at the pathogenesis of, here it is. So you can see the translocation or inversion of RET leads to this. RAS is follicular carcinoma, BRAF is follicular carcinoma, follicular and anaplastic are both P10 and PI3K, and the last one that we were talking about here, PAX8 undergoes translocation. To with PPARG gene, and that is seen in follicular carcinoma. That is seen in follicular carcinoma. Okay. So I hope the genetics are clear of thyroid. So let's go back and look at the question again. Which is not true? So which one is false? Driver mutations in KRAS are seen in follicular. Yes, this is true. BRAF mutations are the most common mutations seen in papillary carcinoma. Yes, this is true. What are the mutations? They are point mutations. Point mutations. These are also in KRAS. These are point mutations. RET rearrangements are seen in medullary. Is that true? RET rearrangements are seen in papillary, not medullary. So this is our answer. PI3K mutations are seen in anaplastic. Yes, this is true. What mutations are these? These are also point mutations. These are also point mutations. So I hope this question is clear now. Which of the following is not true for megaloblastic anemia? Not true. Which one is false? Giant metamyelocytes are seen. Yes, because of nuclear cytoplasmic asynchrony, because there is retarded nuclear maturation but proper cytoplasmic maturation. So because of this reason only you get megaloblasts. So everything becomes really big because of the immature nucleus. So giant metamyelocytes are seen. Where are they seen? In the bone marrow. So this is a true point. Bone marrow examination is important. Unconjugated hyperbilirubinemia may be seen because there can be some mild element of hemolysis because of immature cells being formed. But is there reticulocytosis? No, there cannot be reticulocytosis. In fact, you have reticulocytopenia. You have reticulocytopenia in megaloblastic anemia. And the first change that you see once you supplement the patient with whatever is missing is reticulocytosis. Same with iron deficiency anemia. Supravital staining helps to visualize all except. So which one is not seen on supravital is what they are asking, which means which one you recognize on routine Romanowski stain is what they are asking. So some supravital stains is new methylene blue, then your brilliant crescile blue, azure B is another nice, crystal violet, toluidine blue. All of these are important entities that you see on supravital stain. Now I've brought this table to see what all we require supravital stain for. Howell-Jolly bodies are remnants of DNA. I do not need a special stain to visualize them, so I will use my routine Romanowski stain. Heinz bodies are seen as denatured hemoglobin, and to visualize that I need supravital stain. Pappenheimer bodies are iron deposits. The cells which have Pappenheimer bodies are called siderocytes. Again, a sign of ineffective erythropoiesis. So you see it in these conditions, iron deposits. You don't need a special stain. Hemoglobin H inclusions is seen in hemoglobin H disease, which is nothing but alpha thal. It is seen in alpha thal, and these are beta 4 tetramers, and these inclusions are called golf ball inclusions. You can see the precipitates are all studded along the RBC. So you need, since it's hemoglobin, again I need supravital stain to see it. Basophilic stippling are ribosomes. I hope you can appreciate tiny dot structures. So for this also I do not need special stain. Another question here is reticulocytes, and we already know that we need we need supravital stain to visualize reticulocytes. Now Howell-Jolly bodies is the answer here because I do not need supravital to see Howell-Jolly bodies. Next is reduced beta globin chain production in thalassemia occurs due to which of the following genetic changes? This is a very direct question. Nonsense mutation leads to absent chain production. Gene deletions are seen in alpha thal. Absent chain production allele is denoted by B naught. And splicing mutations leads to reduced production, and that is indicated by beta plus. So the answer here is splicing mutation. Most common translocations seen in Burkitt lymphoma. This is very easy. Remember, B looks like 8, and on the 8th chromosome is a transcription factor named c-Myc. There's a transcription factor named c-Myc, When this is amplified, and which leads to its overexpression due to its cohabitation with a promoter sequence like IgH. So on the 14th chromosome you have IgH, on second chromosome you have kappa, and on 22nd chromosome you have lambda. So all three of them are seen in Burkitt lymphoma. Th21 is seen in AML, and you do not require 20% blasts here to call it AML. So I'm just giving you an extra point there. Now out of these, please remember that translocation 814 is seen in more than 70% cases. So that's our answer. The most common translocation is 814. A child presents with protrusion of eyes, so that is your exophthalmos. Increased thirst and diuresis, maybe patient has diabetes insipidus, and bony defects in the calvarium. A biopsy was performed and electron microscopy figured showed the following. So this is electron microscopy. How do I know? Because it's 50 shades of grey, black and white. And on this electron microscopy, I don't know, but if you can appreciate these kind of pentalaminar structures which have this fusiform ending to them. Can you make out? All of these are basically Birbeck granules. These are Birbeck granules seen in Langerhans cells. So what we are looking at is LCH. We are looking at a case of LCH. And this triad that you see here is actually Hans-Schuller-Christian triad. Hans-Schuller-Christian triad of 3 findings. And since they are all in the skeletal system, this is a case of multifocal unisystem LCH. Multifocal unisystem LCH. And all of these are the markers. In fact, CD207 is Langerin. CD207 is Langerin, which is seen in these Birbeck granules. So I hope you can appreciate these structures here. Which are tennis racket appearance. Okay. This was in your ebook, Langerhans cell histiocytosis. You have unisystem, multisystem. Unisystem, unifocal. Unisystem is eosinophilic granuloma, and Hans-Schuller-Christian triad is multifocal unisystem. And please remember this point, that pulmonary LCH is associated with smoking and it regresses on cessation. For those of you who did not know that MHC2 is a marker, if you know that as 100 and CD207 is a marker, then need not know MHC2 is not. Though hai, that means it has to be all of the above. Okay. What are the other markers? CD1A, HLA-DR and S100. Thorium-induced tumor is, now thorium is seen in contrast. And please remember, both thorium as well as polyvinyl chloride are implicated in causation of hepatic angiosarcoma. Okay. Direct question hai ye. All of the following can occur due to asbestos exposure except. So I will again see if I can show you the list of tumors mentioned in Robbins. This list is bound to increase. There is no doubt about it. The list is bound to increase, and we have to see which ones are the most common ones also now. So in this, let's look at asbestos related disorders, and under asbestos related disorders, the ones that you have to remember, see what does it say here. Lung carcinoma, mesothelioma, laryngeal, ovarian and colon cancer. So these are the ones that are mentioned with lung, laryngeal, ovarian and mesothelioma. So directly our answer becomes testicular carcinoma. So what all you have to remember? Laryngeal, ovarian, colorectal. Mesothelioma is the most typical that occurs due to asbestos exposure, and lung carcinoma is the most common that occurs due to asbestos exposure. Okay. A young patient with cough, wheezing, abdominal pain and deranged liver function tests is being evaluated. So the patient has cough and wheezing, some kind of respiratory involvement. Abdominal pain and deranged liver function tests is some kind of liver involvement. Liver biopsy stained with a special stain. So if you can identify the special stain, maybe you can come to the diagnosis. So in this special stain, do you see these magenta colored inclusions within the hepatocytes? Can you see it's full? It is completely full. So all these magenta color inclusions are pus positive granules, and this is actually a case of alpha-1 antitrypsin deficiency. And alpha-1 antitrypsin deficiency is actually because of misfolded mutated protein that remains within the hepatocytes, and there is a deficiency within the lung, and in the lung it causes destruction of the air spaces, it causes enlargement of the air spaces, and this is the definition of emphysema. So which emphysema do you get? Pan-acinar emphysema. Pan-acinar emphysema in the lung. Now, if you look at the next option, hypoplastic mucus glands, this is a case of chronic bronchitis, actually, chronic bronchitis. Mucus gland hyperplasia is the earliest finding in chronic bronchitis. Smooth muscle hypertrophy with eosinophilia and bronchial walls is a finding on asthma. And smooth muscle and elastic destruction is seen in bronchiectasis. It is seen in bronchiectasis. All are markers for malignant melanoma except the answer here is SOX11. The answer is SOX11. This was an Ames question as well. SOX11 is actually a marker of mantle cell lymphoma. It's actually a marker of mantle cell lymphoma. I put this question so that I could tell you this new marker. Since they asked SOX11, I thought you should know SOX10 is also there, and SOX10 is being used as a marker of malignant melanoma. What are the other markers? S100 and Melan A. So 1, 2, 3, 4, 5 markers that you could now remember for malignant melanoma. Maximum malignant potential is of which of the following conditions? So what they're trying to ask you here is that do you know that first of all polyps are divided into two types, non-neoplastic and neoplastic. Non-neoplastic and neoplastic. And under neoplastic, these polyps are called adenomatous polyps or adenomas, and this is where your familial adenomatous polyposis comes in. Under non-neoplastic, you have inflammatory, hyperplastic, hematomatous, and it is under this hematomatous that you have Peutz-Jeghers polyps and juvenile polyposis syndrome. And comparatively, if you see, neoplastic polyps should have the highest malignant potential. So here the best answer is familial adenomatous polyposis for the simple reason of this classification. Now you'll ask me, why is there an increased risk of cancer with these two? They are hematomatous, and as per our recent understanding, hematomatous is also a kind of neoplastic process. So this classification of polyps will undergo some kind of change in the near future. But just to understand, if you can just grab the concept here, that is neoplastic polyps will as a rule always have a higher risk of malignant transformation as compared to the rest. Okay. Ulcerative colitis and Crohn's disease are both inflammatory bowel diseases. Both of them have an equal incidence of occurrence of colorectal carcinoma. Ulcerative will not have as high risk as familial adenomatous polyposis here. So this question was put to make you understand and to see if you've understood what kind of polyp comprises of familial adenomatous polyposis. Okay, in fact, this is what's implicated in adenoma carcinoma sequence of occurrence of colorectal carcinoma. Next, a child with delayed growth and history of malabsorption. So you have a patient who is a child, delayed growth and history of malabsorption, so some kind of maybe a malabsorptive disorder in the intestine. Pruritic grouped vesicular rashes in the extensor surface of elbows and knees. So now there's some image-based questions I've put so that you can understand how to correlate different subjects and same topic from different subjects. So pruritic grouped vesicular rashes in the extensor surface of the elbows and kidneys. Immunofluorescence study shows the following. So first of all, let's see if you can interpret the immunofluorescence study. What does it say here? Look at it closely. You should be able to appreciate the fact that whatever we targeted has shown up only at the dermal papillae. Can you make out? This is your epidermis and this is your dermis. and these were the tips of dermal papillae, and only they have lit up. And if I tell you that the antibody I used was IgA, then you'll think of what condition? Instantly you should think of dermatitis herpetiformis. And once you think of this should also fit in with your diagnosis. And then you have to take it one step further and try and ask yourself that if a child has dermatitis herpetiformis and he has malabsorption, what could be the syndrome? So syndrome they're talking about is celiac disease or gluten sensitive enteropathy, and we know that in celiac disease you can get crypt hyperplasia. Normal histology is not seen here. Normal histology is seen in lactose intolerance actually. Lactose intolerance, there's no histology. Lipid-laden epithelial cells are seen in A-beta lipoproteinemia. And lipid-laden macrophages are usually a sign of xanthoma or some kind of xanthomatous disorder. But if you have some kind of foamy macrophages in the lamina propria, when they are foamy macrophages, then you have to think of Whipple's disease. So I hope the approach to this question is a little clearer now. You have to correlate a couple of conditions. Have a look at the image again and see if you can interpret how it's only at the tips of dermal papillae.